Hi, I'm Donna McDonald from the Institute of Gerontology at Wayne State University, and I'd like to welcome you to a series of educational videos created to help you on your journey in caregiving, whether as a professional or a home-based caregiver. These videos were made possible by a grant called Functional Aging and Mindfulness for Seniors. This program is the Healthcare Continuum. The presenter today is Dana Rizzo, a well-seasoned RN, not only in hospital-based, home care-based, and now senior living. Please give a warm welcome to Dana Rizzo.
Hi, everybody. Good morning. It's so nice to see you here. And I'm going to minimize this thumbnail video. And here we go. Today's conversation is going to be on the healthcare continuum. And we've been hearing an awful lot about all the changes in insurance and coverage and the inability to stay in the hospitals a longer time and the inability of staying in acute rehab. And we need to understand why this is all occurring. And when we're talking about the healthcare continuum, we're really discussing all of the options and pathways that you have as a consumer of healthcare services. So primary health services, when we're dealing with this, we're looking at continuing care, we're looking at community health, we're looking at medical services, counseling and support, and also health promotion. The big focus in America today is on health promotion. And here we go. Some of the terms that you see, and you'll see these little icons. This is acute care, ambulatory care, behavioral health, case management, health systems pharmacy, home health and hospice, long-term or skilled care, managed care pharmacy, nursing, the payer, physician advisor, medical director, primary care, rehabilitation, and social work. These are just some of the icons that you might see on your screen or at your doctor's office, and just a review of what they mean. Now, what is driving all these changes? Well, the Center for Medicare and Medicaid Services, also called CMS, Center for Medicare and Medicaid Services, CMS, they actually are the ones paying the bills and they're making the rules. So we start out with Medicare and Medicaid setting up rules. Then they write standards of care. Then they create policies. And then there's a whole bunch of requirements that are needed in order for hospitals or doctors or rehab facilities to collect payment. We have to check off every one of their requirements. Then we have to follow all of their regulations. Our medical records must always be transparent, which means that anyone from Medicare or Medicaid, and they call them Joint Commission, they can walk into a hospital, a skilled nursing facility, an acute rehab, or an assisted living facility, or a memory care facility at any time to look at those records to make sure that we are following the rules, the standards, the policies, all of their requirements, and we're following regulations because it's the law. And if we don't do that, they can deny us payment. CMS can say, I'm not paying you for this service. You didn't do what you were supposed to do for that patient. Or Medicare could say, oh, we found one regulation that you didn't meet, so we're going to penalize you several thousands of dollars for that. And they're not kidding around. So CMS, the Center for Medicare and Medicaid Services, are really they are paying the medical bills, and they are in the driver's seat for regulations. And it's a good thing. Prospective payment system. This is the new system that we're putting in place that CMS created that is supposed to improve quality and decrease costs. So prospective payment systems is where reimbursement is established before the healthcare services are rendered and monies are expended. In other words, if they have a whole book on diagnostic related groups, and in this book, they'll have appendicitis, they have pancreatitis, heart attack, total joint replacement. And you're going to get, that hospital knows in advance that if a person is admitted with an appendix attack, appendicitis, that if that appendix has to be removed, the most money that hospital is going to receive is $3,000 for that appendix removal. And they don't care if that patient is 90 with appendicitis, 90 years old, or if that patient is 67 with an appendicitis attack. And you're going to have different outcomes. The 90-year-old may take a little longer to heal than the 67-year-old. But in the prospective payment system, the most they're going to get is $3,000 to the hospital to pay for that appendix removal. Okay, so reimbursement is based upon a specific prospective payment system methodology, and that's their methodology. Every diagnosis gets a certain amount of money to fix. The length of stay and services rendered will result in increased charges on the itemized bill, but will not necessarily result in an increase in reimbursement. So going back to my example, even though the hospital is doing the right thing and they're saying, gee, this 90-year-old woman who's had her appendix removed developed a wound infection. She's going to need to be in the hospital 7 days with IV therapy. The hospital may try to charge Medicare more money for that and explain what happened, but Medicare may still say, nope, you're still getting just $3,000 to remove her appendix. And that 67-year-old, in the meantime, that had their appendix removed, they might be discharged the very next day. So they may have made more money on that person, but they're certainly going to lose more money on the 90-year-old who developed a wound infection. And this is called the prospective payment system. Okay, so keep that in mind, PPS. Okay. Here is the Medicare prospective payment and the shaping of U.S. healthcare. Now, this book is a very similar book to the DRG book, the diagnostic related groups. And that DRG book is the one that I, as a certified case manager, accredited case manager through the ACM, I would use that book to go down to the emergency room. And if a doctor said, I'd like to admit this patient, I'd have to say, okay, explain to me why. Why can't we treat this patient in 48 hours and then send them home? Keep them in as observation. Do not admit to the hospital. Those two words are very big differences. So, I would work with the doctor, and the doctor said, well, we've got this, 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 and this. And I'd have to go through that book to see if they met the criteria. If they didn't meet CMS criteria for admission, that doctor could not admit them, even though he or she may have felt in their gut that this person needed to be admitted and not just kept under observation. Now, the observation rule, when people go into the hospital and they're brought in under observation, they can stay in observation 48 to 72 hours. And that means that the doctors and nurses are in the emergency room and they're in a special observation unit. And we are monitoring that patient very carefully to see if the doctor is going to be able to rule in the diagnosis or rule it out. In other words, that doctor might say, I think they're having a heart attack, but I'm not sure. But we'll watch them closely for 72 hours. We'll run EKGs. We're going to do routine lab work. We're going to monitor their signs and symptoms and their vital signs. And if it ends up that all that discomfort was related to gastric reflux disease, then we're going to rule out the heart attack. The doctor will order Pepsid or some other antacids, and they're going to send them home. But after 72 hours, if the EKGs are changing, the lab work is changing, and the doctor says, we're going to rule in heart attack because all of these cardiac enzymes are now changing. I was right, they're having a heart attack. That's when they are flipped into admission status. And the admission date starts from the day the doctor wrote the order for admission. It does not go back to the day they showed up in the ER. Okay, that's something else your care managers and case managers will explain to you in the hospital system. Now, the Inpatient Prospective Payment System, IPPS, they're looking at diagnostic related groups, okay? And this reflects the patient's severity and the resource consumption. Payment is not equal among all hospitals because some inner city hospitals charge more money than a small rural hospital for the same treatment. They will reduce payments for transfers and post-acute transfers for some DRGs, meaning that if one hospital says, I'm a small rural hospital, I really cannot handle this massive heart attack patient, I'm going to send them to a big inner city hospital. That smaller hospital is going to get reduced payment because they're transferring them to a huge inner city hospital where they can better be treated. Outlier payments are complex. The hospitals can apply for like that 90-year-old woman that had the appendix removed, appendectomy. The hospital might say, hey, listen, she got a wound infection. CMS, you've got to give me more money because she stayed 7 days on IV antibiotics. So we will write an outlier payment and we will ask CMS for more money to cover the antibiotics, the 7 hospital days, etc. And there is an equation that they use for that. And this is the reasonable cost formula. And this is the allowed charge, which would be the $3,000. This is the Medicare overall outpatient ratio of cost that they'll give us. And this equals the CMS rate. And this is the reasonable Medicare rate, which means that they'll say, well, here's $3,000 for the appendectomy to remove her appendix. For the cost of the 7 days of IV antibiotics and the 7 hospital stays, etc., we'll give you another $2,000. And so the hospital will get $5,000 for that appendectomy of the 90-year-old woman. So this is what where the CMS is looking at. This is the basic reasonable cost formula for outliers. Now, in a healthcare continuum, what we're really looking at is healthy living and prevention. There is a huge push that Americans lose weight, stop smoking, reduce their stress, really manage their lives, have a better life-work balance. And then if there is a diagnosis, then we're going to treat it, hopefully at the doctor's office. We're going to see the treatment, and then we're going to, the doctors will advise home care services if needed. And this is one of the connected care and health informatics that they're looking at. They want this type of a continuum where you avoid the hospital at all costs, because that's where CMS is spending the most money. And CMS is trying to keep the costs down for healthcare. So that's why they're going more for the socialized model. Socialized model is an accountable care organization or an HMO, and it's very much like the Kaiser model, where everything is on healthy living and prevention, and we're going to try to prevent the disease from occurring. For instance, all of those people, I think it's 49.9% of Americans have pre-diabetes. Well, if we can get those 49% of Americans to lose weight, to walk every day or bicycle or swim, we can get their weight under control, then we focused on prevention of creating another diabetic. And that means that that person is going to feel a whole lot better, but they're also not going to go on to a diagnosis of diabetes from pre-diabetes. We're going to be able to really cut costs because now they're not even a diabetic or a pre-diabetic because they've lost all that weight and they were healthy living. So this is the whole focus of the healthcare continuum, healthy living and prevention. In the continuum of care, we have a lot of options. When we are really, really sick, we go to the hospital, such as a stroke. Signs and symptoms of a stroke or a heart attack, you don't fool around. You call 911, you go right to the hospital by ambulance. Once you get to the hospital and you recover, Then they're going to give you the option of going to a rehab skilled nursing facility. And these are very, very different. Acute rehab is a hospital by itself, and acute rehab gives you up to 3 hours of physical therapy a day for about 2 to 3 weeks. A skilled nursing facility provides rehab, and these are both places where you stay overnight. You stay there for the 2 to 3 weeks. In a skilled nursing facility, you're going to get physical therapy, occupational therapy, speech therapy, medication oversight, just as you do in acute rehab, but they're only providing 2 hours of physical therapy a day. So usually in a skilled nursing facility, and it's often referred to as a SNF, you get to stay 20 days with Medicare paying 100% if you meet criteria to stay. Now, if they discover that you have you've been screened and you have polychronic complex, which means maybe you have heart disease, diabetes, kidney disease, you've got a lot of things that are making you feel bad, you're going to require more technology and more care in order to stay healthy and stay out of the hospital. And you're going to have a lot of consumer engagement activities. You're going to have social networking. You're going to have a transitional care manager that will call you at your home to make sure that you're following up with your diet, exercise, medication, that your caregiver is there to drive you maybe from home to outpatient therapy and getting you to and from your doctor's office visits. They also will talk with you about behavior modification programs, smoking cessation, weight control, stress management, etc. Then you're going to go into the health and wellness. Once you're well enough, they're going to get you into programs that promote health and wellness. And these will be things that will encourage you towards healthy fitness, healthy eating, healthy lifestyle, and diet. They're going to encourage you to follow up with your neighborhood clinic or your community clinic and your doctor's offices, okay? And neighborhood clinics would be like your urgent cares. Community clinic would be your transitional care clinics where they have a doctor there, social worker, registered nurse that are maybe monitoring you more closely, your blood pressure, your kidney functions, your diabetes, your heart function, all of those things. And they're really trying again to help make you to decline using the readmission to the hospital. All of this intervention is to keep you out of the hospital so that you recover, that you have a much healthier lifestyle, and the cost of healthcare is going to decline. Okay, so this is one model of the continuum of care that everybody is adopting. Now, we have medical care and social care. In a community hospital, like what you might find in your community, in your neighborhood, they offer emergency care and acute care. There's an emergency room, there's a maternity ward, there's outpatient clinics. If you have a chronic disease, this is all for acute care, like if you have an appendix attack, or if you have an acute heart attack, or if you're having a small stroke. Now, if you advance down the continuum into needing chronic care means that they may offer you a skilled nursing facility or a nursing home. And they're going to do telecommunication where there's doctors and nurses in the nursing home that are monitoring you, but also contacting you by telephone. Or they will have a machine in your house where you can plug in the machine, you can put your finger into one portal, your arm into the cuff, and it's going to monitor your height, it's going to monitor your blood pressure, your pulse. It will monitor your weight. It'll monitor your blood oxygen saturations, how much oxygen is in your blood. Now, if you need long-term care, then they're going to do remote monitoring. And this becomes more social care because the medical care has stopped or almost stopped. We've treated the acute problem, we've treating the chronic problems, but if you've got long-term health problems like kidney disease, heart disease, lung disease, things like that, then you're going to go into long-term care. And we'll do remote monitoring again. They may suggest to your family that while they go to work, that they put their loved one in an adult daycare center where they can be dropped off at 8 or 9 in the morning. They will get breakfast, lunch, and 2 snacks, and then you're picked up at 5 p.m. at night. And that is a payment plan that is on a sliding scale. It's a 501c3 nonprofit. And you may pay as little as $16 a day, or you could pay as much as $65 a day, depending on your income. And then, of course, home care. And for a period of time, they can provide you with a home RN, home physical therapist, home occupational therapist, home speech therapist, if needed, and if you meet the criteria. So again, we're looking at working together with medical care and social care to reduce the cost to Centers for Medicare and Medicaid Services, CMS. Here is the self-care continuum, and this is what they really want Americans to be thinking about. In the self-care continuum, we start out with making pure self-care, and it's the individual's responsibility. It is our responsibility to make better daily choices, to not smoke, to exercise, to eat healthy, to keep our blood pressure under control. It is our lifestyle choice that we go for a walk every day, that we take yoga or meditation, because all of these things can manage. We have self-managed ailments, meaning that even though we're pre-diabetics or diabetics, we are managing our blood sugar through diet, exercise, and medications. If we continue to have minor ailments, we may be able to go to our primary care physician and get treatment for that, such as if we come down with the flu, or if we come down with pneumonia or one of these other illnesses that are out there, then we can go to the doctor. Those are minor ailments. We can get them fixed and stay out of the hospital. Nobody wants to go to the hospital because you stand to gain a lot of extra infections there. In long-term conditions, such as long-term heart disease, emphysema, chronic obstructive pulmonary disease, these long-term conditions sometimes can tip us into requiring medical care. And if we have an acute exacerbation, for instance, of emphysema, let's say that it's the pollen season, it's fall, and all the seasonal allergies return, and that triggers your emphysema and your COPD, and you're really having a lot of bronchospasms, you're not breathing very well, you're creating a lot of extra mucus in your lungs. Well, you are definitely going to be needing to see your doctor, and your doctor might very well admit you to the hospital so that we can put you on IV antibiotics for a while. There's also compulsive psychiatric care, which means that people need to become more aware of the symptoms of anxiety, depression, how they're feeling, and seeking out healthcare professionals to take care of that with them. And then, of course, you have major trauma. In major trauma, like major strokes, heart attacks, motor vehicle accidents, the ambulance is bringing you directly into the hospital, and it's pure medical care, which becomes the professional responsibility of the healthcare team. So again, we are focusing our country on pure self-care and individual responsibility for their healthcare choices. Here is a medically home virtual hospital. You can actually go to the hospital. They can start you with antibiotics, and then you'll be discharged home. They have even created an outpatient IV access clinic where you can be driven every day or drive yourself to get IV antibiotics, just like you get chemotherapy. You drive to the hospital, you get your chemo, you get your radiation, and then you come home. They can do labs there in your home. They can even provide stat IV access in your home. A registered nurse can come to your home and start an IV and start you on medication. Doctors also have the ability to write prescriptions to get you into skilled nursing rehabilitation, but you have to be in the hospital for 3 qualifying midnights under admitted. You need a 3-night admission order, not observation, in order to qualify to go to a skilled nursing rehab. You can even go to your local doctor, nurse practitioners, and doctor's office for continued follow-up. Also, there are clinics that, like Kaiser or freestanding clinics that have doctors and nurses there. And these clinics, like urgent care, can take care of you pretty quickly and get you back in sync so that you can take care of yourself independently at home. In the senior living spectrum continuum, we have a cost access, which is vertical, and then we have the level of care and supervision services, which is here, and it's horizontal. This bubble graph shows how different types of senior care overlap and the relationship between the level of care and the cost. Now, after leaving a hospital, you have options, many options. You can go to after the hospital, if you've had your 3 midnight qualifying stay as admitted, you can qualify maybe for a nursing home where you'll get rehab and you'll get 24-hour supervision by a skilled nurse. And you'll have physical therapy, occupational therapy there. And as you can see, the cost is moderate and the level of care and supervision is pretty high. And Medicare can pay for these skilled services. Medicare can also pay for hospice care or palliative care, which is an arm of hospice, which helps to relieve symptoms. Hospice care provides end-of-life support, and it can be provided at home or in a special hospice community care facility. And again, Medicare will pay for that. And it's a very comfortable environment, and they're really protecting you and keeping you free of pain and keeping you as comfortable as possible. Now, you can also have in-home senior care, which means that you can discharge home, and especially if you have a caregiver, and hospice can come there. We can have home PT, home physical therapy, speech therapy, and a registered nurse come in, and they come in, the RN will be there maybe once a week. Your PT, OT will come once or twice a week on alternating days. Now, this is the lowest cost to Medicare and Medicaid. In-home senior care is the lowest cost. So a lot of them want to discharge you home with home health care services. The thing that you as a consumer have to be aware of is that not all home health care companies are the same. It's important to look up Medicare.gov and find out their ratings. A lot of these home health care companies do not have the foundation to provide you the best physical therapist, occupational therapist, or speech therapist. Do your research, talk to your neighbors, talk to your healthcare workers about what is the best home healthcare company out there for me that accepts my insurance so that I'm not balance billed for anything. Now, after you complete the nursing home, or maybe straight from the hospital, your family will say, we've had a talk with a doctor and it is not safe, Mom or Dad, for you to go home alone. So we're going to offer you assisted living. Now, assisted living provides, you pay for your room, and your rent, and Medicare will pay for your skilled services. Like in your assisted living, we're going to help you with activities of daily living. We will help you with all your personal care, such as meals, hygiene, entertainment, and free transportation. But if you need physical therapy, occupational therapy, speech therapy, we will bring in a Medicare certified home health care company that will provide you with those things right in your home, in your new assisted living apartment home. Okay. And that's very, very nice. The nice thing about assisted living is that it provides you with a lot of socialization and activities that keep you engaged and happy. Now, a lot of these assisted living communities also offer respite care. And respite is a wide range of services, and it's in a assisted living usually, and it can be 30, 60, or 90 days. And you're renting month to month, so it's not a big investment. But if you're recovering like that 90-year-old woman from a wound infection and an appendectomy, she's going to need help. She lives all alone in a multi-level house, and her kids live out of state. So for her, coming to assisted living and a respite care, staying for 30, 60, or 90 days, and then when she's up on her feet and feeling 100%, then she can discharge back to her private home. Now, there's another option, and the other option is that you can go to a CCRC. And a CCRC is a continuing care retirement community. And CCRCs are a buy-in for the care for the rest of your lives. You actually own the apartment, you buy it, and it includes all levels of care from independent living, assisted living, memory care, and even a skilled nursing facility. CCRCs are not for everybody. Some people don't want to have that big outlay of money to buy an apartment. And the outlay of money could be $400,000, $500,000, $600,000. And when you die, your heirs can sell that apartment and they can recoup some of that expense. Now, there's also another option is living in a, and you can see CCRCs are on the very high end of cost. Retirement communities are on the higher end of cost. A retirement community is just like going to any apartment building. And but these focus on people over the age of 55. And you rent or own your apartment in the community. It's only for seniors. Usually they have no children rules. You have access to social activities, valet services, and they even have emergency call systems like a button that you can press and 911 will come. You can also go to a senior apartment, which is for anybody. You can just go to any apartment building and say, I want to rent an apartment. And a senior apartment is nice because it usually attracts other people of similar age. There can be a senior co-op where, you can have a congressional where you're part of a church or a community center. And these provide you with support from other people your age. They can provide you with usually one meal a day, usually lunch. And there's lots of activities like pickleball. They play cards. They have entertainment. They have speakers coming in. The other option, which is very low cost and a lower level of care, is the adult daycare centers. These adult daycare centers are low cost. It's only daytime care, socialization, entertainment, and supervision. And this is the one I was telling you that is sliding scale, and it's usually through the counties. And then, of course, we have independent living. Independent living is part of assisted living communities. And a lot of the communities, senior living communities, they offer independent living, assisted living, and memory care all under one roof. but there's 3 different communities with their own staff under one big roof. In independent living, you often have total freedom with access to other seniors. You have lots of entertainment, you have emergency help. And in some of the independent living communities, they offer breakfast and dinner 7 days a week, 6 to 9 activities every single day, indoor swimming pools, free transportation to and from your doctor's office. And again, you can see where the cost for that is quite low, but you still have a level of care and supervision. They even provide housekeeping and laundry every other week with a full washer dryer in your rented apartment. And they also have a full kitchen in your rented apartment. So all of these things are your options. There is another for dementia and Alzheimer's care, and this is often in a senior living community, and they provide a high level of daily supervision with activities of daily living assistance. And they offer specific programs for patients with memory difficulty and dementia, and they're especially trained staff that know how to communicate and how to assist a person with cognitive deficiencies such as dementia and Alzheimer's. So this is your bubble graph that was really showing you the different kinds of senior care and how they sort of overlap and the relationship between cost and the level of care and supervision. Now, Medicare, just a little something to tell you about. Medicare was enacted by President Lyndon B. Johnson, and it was Title 18 of the Social Security Act of 1965. And it extended health care coverage to almost all Americans age 65 or older. And Medicare is a wonderful benefit of this country that we provide for our American people. We have all paid into the system, and we all deserve to use the benefits. So when you're being asked in a hospital, do you want to discharge home? Do you want to discharge to a skilled nursing facility? Do you want to discharge to a private senior living community? If you want to use your Medicare benefits, you should always say, I would like to discharge to a skilled nursing facility if you need that level of care and there's nobody at home to help you, or I will go to the assisted living community. I'll pay bed and board, but I want Medicare to pay for all of my therapy sessions. Or I want to go home and I want Medicare to pay for my home physical therapy, home speech therapy, home occupational therapy. So Medicare is a wonderful gift to all Americans, and we've paid into the system. Now, the retrospective payment system. Now, this is the old system that broke Medicare. This is the old retrospective payment system. Retrospective payment system was when I was a young nurse. And this was reimbursement to the hospital was established after the healthcare services are rendered and all the costs had been incurred. And the payment, the retrospective payment charges increased with the length of stay, and it translated to increased charges on the itemized hospital bill, and also an increased bill for reimbursement to Medicare or Medicaid. It also, the retrospective payment system encouraged an increase in the services rendered, meaning it did not curtail the doctors from ordering every single test under the stars, because with every test, it incurred increased charges, increased use of labs inside the hospital, increased itemization on the bill, and of course, an increased bill was sent for reimbursement to Medicare and Medicaid. So this retrospective payment system really was too expensive for this country to continue. And the reason for it is, we didn't have a lot of technology way back when, but one doctor, and I would see it all the time, one doctor would attempt to read the other doctor's writing to see what that doctor, that specialist wrote, what were his findings or her findings. And they wrote in scribble. You couldn't even read it. So this doctor B would say, you know what, I can't read what they've written. I'm going to go ahead and reorder another chest x-ray, another EKG. I'm going to order this panel of labs because I can't read what this guy wrote or this woman wrote. So there would be a lot of duplication of tests. There was a lot of duplication of services. And the hospitals loved it because the hospitals are saying, oh, this is great. I'm making money hand over fist from Medicare and Medicaid, because instead of the patient being in the hospital for just 2 days, the hospital, the doctors were encouraged, because they also got paid every day from Medicare and Medicaid. They were encouraged and incentivized to keep the patients in the hospital as long as possible. And then finally, they would discharge them, and Medicare would get a bill for like that 90-year-old person that had the appendectomy, that had a wound infection. Instead of being in the hospital 7 days, she might be in the hospital for a month. And it wasn't necessary. It really wasn't necessary. And yet all of that money was coming out of the taxpayers, because we're the ones paying CMS. We're paying all the taxes so that Medicare can live. So they're asking all of us to be stewards of the Medicare, Medicaid system, meaning that we only use what we need, and then we leave the hospital so that we free up a hospital bed for someone who is acutely ill that needs that high level of care. And in this retrospective payment system, there was so much abuse. I remember a woman being dropped off in the emergency room, and her daughter told the emergency department team, she's been running temperatures. She's had a very high fever, constipation, and I don't know what to do with her. And she dropped the patient, her mother, off. And when we spoke to the patient, we noticed that she never had a temperature. She was having regular stools. She had no discomfort whatsoever and never ran a temperature, not morning, not evening, not at nighttime. And we asked her, we said, you know, your daughter said that you had temperature. She says, oh no, my daughter dropped me off because she wants to go to the beach for a week and doesn't want to take me. So you see, this retrospective payment system really had to be fixed. Now, we now do something called a bundled payment, and it's based on the DRGs. So, and this means that there is a single fixed price for services by 2 or more providers for a specific condition over a set period of time. Typically, it includes a facility and professional services and a post-acute care. The goal is to incentivize improvements in care quality, coordination, communication, and efficiency. And this is what we do. In the old days, for cardiac bypass surgery, for instance, it used to be that the hospital got billed Medicare for a lump sum of money. The surgeon billed Medicare for a lump sum of money. And then if the person needed to go to an acute rehab or cardiac rehab program, they billed Medicare for a lump sum of money. So in the end, the cardiac bypass surgery might cost the Medicare system $100,000, let's say. In the bundled payment model, based on a DRG, a diagnostic related group, we know that for cardiac bypass surgery, the most we're going to get is $25,000, the most. So Medicare says, guess what? This guy's coming in for cardiac bypass surgery. The most you're going to get is $25,000. Here's a bundled payment, $25,000. Out of that $25,000, you have to pay the hospital, you have to pay the surgeon, and you have to pay for post-acute care. And that's why the hospitals are talking to the surgeons, and the surgeons are talking more to post-acute care. That's why you're having improved quality, improved coordination of services, and more efficiency. Because now that cardiac patient is not incentivized to languish in the hospital bed. They're incentivized to get up, to work with PT, OT, to change their lifestyle, to get out of the hospital as soon as possible, to go to rehab, cardiac rehab, and to really focus on their lifestyle and their strength and getting better. So that's a bundled payment. Bundled payments for improved care. CMS really believes in this. So you have to discharge patients to home because that's cheaper versus a post-acute facility like a skilled nursing facility if they meet the criteria. The hospitals and the case managers are very ethical. If a person needs to go to a skilled nursing facility, they're going to send them there. If they meet the criteria, they're going there. But we're going to save that opportunity for patients that really need it. We're not just going to give it willy-nilly to a patient who says, yeah, I don't feel like going home. I want people to bring my food to me. Yeah, I don't want to go home. You know, those people can go home and they just need to work on getting better with home therapy and home services. They want to optimize patient post-acute care length of stay, which means that in acute rehab, where we used to be able to keep them for 6 weeks to recover from a massive stroke, we've only got 2 to 3 weeks to do it. We have to optimize that 3 hours of physical therapy every day, occupational therapy and speech therapy. And we have to really work that patient so that they get on their feet faster and that they get better quicker. And we also want to minimize patient readmissions. Remember when we talked about the fact that if you go home and within 30 days you bounce back into the hospital, there's a penalty to the hospital. The hospitals can be penalized up to millions of dollars. So the hospitals are going to work to get you discharged to the right level of care, get you the right care and treatment you need so that you will not have to be readmitted. You're going to feel better. You're going to live a better quality of life, and you'll stay out of the hospital because nobody really wants to stay in the hospital. Hospitals are places where there's a lot of bacteria and viruses. Here is the DRG, Diagnostic Related Group Bundled Payment. Out of this bucket of money, where the hospital has to pay for the drugs, all the hospital supplies, all the physicians, and of course, any of the procedure costs like surgeries or cardiac catheterizations, x-rays, etc. So the bundled payment again, the hospital is getting one large payment. They're paying their physician, their radiologist, their anesthesiologist, and their surgeon. There's one big bundled payment, and that is very helpful in keeping costs down. Again, here's the healthcare continuum. In the hospital, after a hospitalization, this continuum shows that you have the ability to go to an inpatient rehab facility. They call it an IRF. And that's if you qualify for acute rehab and that you are able to do 3 hours of therapy a day. You're not too weak. Or if you're too weak and you can't do 3 hours of therapy a day, they may give you the option of going to a skilled nursing facility called a SNF, skilled nursing facility. And there you get to stay 20 days if you meet criteria, and 100% of that first 20 days is paid by Medicare. But after day 21 to day 100, there is a copay of $278 a day, give or take. And your secondary insurance might help you pay for some of that, but not all of it. The balance will be your responsibility to pay. From the hospital, you always have the option of going to outpatient rehab. That's what I did after my total hip replacement. My husband had to drive me for 2 weeks, and my friends to early outpatient rehab. And I got a lot of therapy in, and then I would get to go to breakfast with my friend or my husband, and it worked out. Or you can go home with home health. I opted not to have home health because I felt that I was young and strong enough, and I wanted to save my money to go to the outpatient rehab. Now, if you're coming from a physician's office and you have a minor ailment type thing, your doctor, if it's anxiety, depression, they may refer you to someone for behavioral health. And Medicare will help pay for that. They may send you to outpatient social network with a group of therapists that can help you. They may send you to hospice or palliative care. If you're not quite ready for palliative, the palliative care means it relieves the symptoms. And you can still, under palliative care, receive antibiotics and all kinds of things. But as your illness deteriorates, your health deteriorates, and your illness progresses, then you may need hospice. Okay, but these are usually done on an outpatient basis. But you can see how we're really trying to provide you with the whole spectrum of healthcare services on the outside of the hospital. Now, okay, in a stroke recovery process, here's a flow chart to show you. You enter the hospital because of the stroke. Do you require complex medical care after the stroke? If the answer is yes, they're going to ask you to go to long-term acute rehab hospital for 3 hours of therapy a day to regain your strength. If you do not require complex medical care, then they may send you just to a skilled nursing rehab facility, or they may send you, again, if you are no longer so weak, you've gotten stronger, you'll go to an inpatient rehab facility, which is acute care facility. If your illness is catastrophic after a stroke and you need complex medical care, perhaps you're no longer able to walk or swallow, you may go to a long-term acute hospital, which is called an LTAC. LTAC, L-T-A-C, LTAC, long-term acute hospital, where they can provide you with 24/7 nursing care. And it's very intense, and they charge Medicare more money than a skilled nursing rehab facility. So leaving an acute care hospital, your choices for discharge are that you can go home, which is the cheapest to CMS with skilled services. You can discharge to a skilled nursing home, or you can discharge if the illness is catastrophic enough, you can go to a long-term acute care hospital like an LTAC. In a continuum of post-acute care for COVID positive patients, they actually, these patients came in, they had telephonic follow-up, remote monitoring, and supplemental oxygen was set up in their homes when they left the hospital. Some of them, if they had no home, they went to a hospital-funded temporary living place for homeless people like assisted living or a hotel. Some of them had home health, transitional services, hospital-supported physician backup. Some of them with COVID actually went into hospice. And some of the hospitals actually created in-hospital hospice units. So the patients that were dying from COVID could go into hospice and be made very comfortable and given everything they need until their final days. Some COVID patients went to COVID positive units in skilled nursing facilities. Some of them actually needed ventilators to help breathe, and the skilled nursing facilities provided that. Some of the COVID patients went to inpatient rehab, and they had a COVID rehab unit, and they got intense therapy, 3 hours a day to regain their lung function, their physical functioning, etc. Some COVID patients, because they had long-term serious side effects from COVID, they went into the LTACs, the long-term acute care hospitals, LTACs, and that's where they stayed. And these were the most complex because these LTACs cost a lot of money to run. So what happens when a patient is discharged from the hospital? Well, when that patient is discharged, this makes a bed available to another person who needs a high level of care. You will still receive care after leaving the hospital. After discharge, you'll go through a transition of care. That means you will now have a different level of medical care outside of the hospital. What should be included in discharge planning when you're meeting with your case managers in a hospital? You ask your case manager to include all of the information on the types of care you need, where you're going to be discharged to, and who's going to provide the care for you. It should be, you should have a discharge plan that's written in simple language, and it should include a list of your medications and the dosages and the usage of drug information that you need. Your transition of care model is this. You're going to find that once you're discharged, you may have a transitional care nurse or case manager calling your home to make sure that you are receiving your medications, that you're following up with your doctors, that if you need oxygen, you have your oxygen, etc. Transitional care is about education and promoting self-management, collaborating with all the healthcare workers, promote continuity of care, fostering collaboration with the patient, screening the patient and making sure that the caregiver understands warning signs if they're going back into heart failure or perhaps their emphysema is getting worse. They'll provide staffing and maintaining relationships, and they will engage the patient and the caregiver. And they're assessing and managing for risks and symptoms and the return of those symptoms so that that transitional care manager can say, hey, I think your COPD is getting a little bit worse. I think your heart failure is getting a little bit worse. You had a 5-pound weight gain. I think tomorrow you need to go see your primary care doctor. I'll make the appointment for you. Transitional care management has all of these components, and it's really helping to keep people out of the red zone where they get into trouble with their health and keeping them in the green zone because they know what the signs and symptoms of problems are in the yellow zone, which means caution. So early treatment, early access means you're going to get better faster. In population health pyramids, we're looking to make people in the low risk category. If you're at medium risk, you'll be here. And if you're at high risk, you're going to be at the top of the pyramid. And population health, doctors refer to this also as levels of resilience. So if you are low risk for side effects, low risk of complications, you're going to have high resilience, meaning you're going to come on back fighting, okay? If you're at medium risk, maybe you've got hypertension and you're pre-diabetic, they know that it's going to be a little bit of a struggle for you, but your resilience is pretty moderate, pretty medium. So you're going to need maybe a little more time to recover, but you will recover. High risk people are people that have uncontrolled comorbidities. They have end-stage heart disease. They have problems with their kidneys, problems with their lungs. And these are people that when they get the flu, it becomes monumental because they have low resilience and they don't have any reserves to fight back the illness. So these things kind of flag the professionals in the hospitals. So in summary then, on the healthcare continuum, we know that we start out with primary health services. We have continuing care, community health, medical services, counseling and support, and health promotion. And this is really saying the same thing, just in different colors. It's important for you to use like your senior community centers, because in your senior community centers, they can provide you with, your county government can provide you with free COVID screenings, free blood pressure screenings, cholesterol screenings, anxiety and depression screenings, all free. And the quicker that you get treatment and you seek consultation the better you're going to feel, and you're going to be able to enjoy your longevity. Thank you, everybody, for being here today. Dana Rizzo. Thank you. Have a good afternoon.